Hello, and welcome to our online education presentation on positioning for comfort and growth. I'm your speaker, Dr. M. Therese Verklan. The educational program is sponsored by Philips Healthcare, and it is accredited for CEUs. In the 1960s, the NICU was established to provide care specifically for critically ill newborns that were 36 weeks and older. Since then, it has evolved into a state-of-the-art technological center that provides a wide range of services for infants as small as 23 weeks. Advances in neonatal care have led to noteworthy changes in the survival of high-risk babies, although there remains significant morbidity related to the individual neonate's immaturity, prematurity, and severity of disease. Positioning and developmental care practices may help to mitigate related complications by promoting positive growth and healing. This presentation will discuss motor and musculoskeletal development, the use of therapeutic positioning, and positioning to prevent unplanned extubation. Let's first discuss motor and musculoskeletal development. During the care of the acutely ill and recovering neonate, care is typically directed using a developmental or a neuroprotective approach toward the main sensory systems as well as to the baby's overall physiologic condition. Nurses are in the perfect position to evaluate movement and posture in the recovering baby and to promote motor development. The use of positioning aids can be used as an adjunct therapy to prevent or mitigate musculoskeletal deformities. Looking at structural development. At the end of the second week of gestation, blocks of mesodermal tissue develop into the sclerotome, which gives rise to the ribs, the vertebrae, and later cartilage, bone, and tissues related to the skeletal system. The mesodermal tissue also forms the dermomyotome, which is the muscle and the skin cells. During the fourth week of gestation, the vertebral column develops as the sclerotome cells form the vertebral arches and the vertebrae. Bilaterally, mesenchymal costal processes form the ribs from the thoracic vertebrae. And the sternum is developed when the first 7 rib pairs fuse at the midline. Limb buds appear in the fourth week of gestation, and they lengthen in the fifth. Ossification is present in the center shaft of the long bones by week 12, while the ends of the bones remain cartilage. Throughout prenatal life, the center shaft, or the diaphysis, has the most growth in thickness and density. Any injury to the limb buds during the 4th and 5th weeks can result in deformities such as polydactyly, club foot, partial absence of an extremity, and other limb abnormalities. Often critically ill neonates have prolonged periods of immobilization due to sedation and mechanical ventilation, which may promote calcium loss and bone demineralization. And you see on the slide that this baby has syndactyly, which is webbing of the toes, plus polydactyly, which is too many digits, in conjunction with a syndrome. From week 6 through 8 of fetal life, the joint or the articular structures are formed from the synovial membranes and the connective tissue that develops between the bones at the points of articulation. Mechanoreceptors are also developed to help guide proprioception and awareness of the speed of movement and the direction the body is moving in when in locomotion. As the fetus moves in the amniotic fluid, the motion is really shaping the joints. Throughout growth and into adulthood, there is further joint molding due to pressure from movement and the forces of compression during that movement. Very interestingly, full-term neonates actually have decreased range of motion and extensibility in their elbow and knee and hip extension. This is due to intrauterine position, crowd knee, and limiting fetal movement, and we consider this normal. Their knees and elbows are going to regain full range of motion in about 3 months, and their hips by about 1 year of age. By 20 weeks of life, muscle tissue has differentiated into the type 1 or slow, highly oxidative, and type 2 or fast, low oxidative twitch fibers. It's not until the end of gestation that there's an equal proportion of both muscle types. Because the preterm baby has a lower proportion of those fatigue-resistant fibers, those type 1 fibers in the diaphragm and intercostal muscles, the preterm baby is very vulnerable to fatigue when in respiratory distress. And that's why they tire out so quickly. And you see this baby being supported by CPAP for respiratory distress. Movement has been noted in the embryo at about 7 weeks of life. The movement is generally slow neck extension, followed by startles. Startles are seen as fast movements that occur in phases rather than as continuous movements. With the startles, the neck and trunk have a secondary involvement. At approximately 9 weeks, general body movements emerge that use whole body complex movement patterns. At this time, isolated limb movements occur as well as head and neck rotation and extension movements. At 10 to 12 weeks, breathing patterns emerge and the jaw can be seen opening and closing. Sucking and swallowing movements are seen at about week 13. Swallowing is very important in regulating the amount of amniotic fluid. For example, if there is polyhydramnios, esophageal atresia is ruled out because the fetus is not able to swallow the amniotic fluid. After 20 weeks, documentation of fetal movement becomes extremely difficult because of the size of the fetus. It's difficult to visualize the entire body during an ultrasound for prolonged periods of time. There is a continuity of movement from fetal to neonatal life that is endogenously generated and predictive of brain function. With disruption or injury to the neurological system, there can be changes in the quality of general movements. It's not uncommon for NICU survivors to have difficulty with both fine and gross motor movements. The extremely preterm baby that you see in the picture is only a few days old, and already there's a flexion contracture developing in the right wrist. It's very, very difficult for an ill or a very preterm neonate to deal with the forces of gravity. The technology in the NICU is necessary to assist the survival of many preterm and term neonates. However, it can also interfere with motor development continuity. Long periods of relative mobilization, use of ventilator equipment, IV lines, arm boards, foot boards, and placement on the relative hard surface of incubator mattresses can disrupt normal motor and muscle development. Use of developmental care interventions that promote proper alignment and positioning of the body and extremities, along with the use of neuroprotective approaches to handling, can facilitate the continued positive growth of muscles and movements. Because of the fetal environment and fetal movement activities, the term neonate has an entirely different repertoire of movements when compared to the preterm neonate. In utero, fetal existence was one primarily of movement, in which the fetus was floating in the amniotic fluid and then with maturity experiences the rhythmic movements of the mother. The sense of touch, temperature, pressure are all well developed, and receptors for these sensations are found in the baby's skin. At term, a healthy baby has strong muscles, strong posture and tone, and effective movement to respond to the new extrauterine environment. Depending on the degree of prematurity and immaturity, the neonate can have difficulty adjusting to the new proprioceptive stimuli, as he or she is now lying flat on a mattress instead of being supported by the mother's muscles or amniotic fluid. Essentially, the baby is weight-bearing before the musculoskeletal system really is mature enough to support that activity. As mentioned previously, sick and preterm babies have difficulty dealing with the forces of gravity and are seen in much more hypotonic positions. Passive muscle tone can be evaluated by how much resistance can be elicited to passive movement. Term infants have well-developed passive flexor tone because of how they were crowded against the uterine walls in the last trimester. The strength of that tone can be seen in the full-term baby's ability to have some head control, position the hands and extremities to the midline, and have a well-coordinated suck, swallow, breathe reflex. Even when reaching term, though, preterm infants, especially if they're less than 28 weeks, tend to lack the same degree of passive muscle tone as their term counterparts. The lack of the preterm baby's ability to have postural control may be related to the lower proportion of fatigue-resistant fibers in the skeletal muscles, those type 1 fibers. The preterm is not able to maintain the needed muscle contraction that's required to maintain posture against gravity. We know that flexor tone develops from the toes to the upper extremities. Just picture those stick men in the Valor Gestational Age Assessment form. We have one on the screen. You use this in practice every day. And if you just look at the very top one that says posture, you can see that there's ankle dorsiflexion at about 25 weeks, beginning knee and hip flexion at around 30 to 32 weeks, and arm flexion at about 34 to 36 weeks. It's therefore very important that the bedside care provider provide the proper support at the right times to encourage normal growth and development of extremity flexion. In general, it is expected that when a preterm neonate reaches 40 weeks corrected age, that they should have the muscular and postural abilities of a term neonate. And as I said previously, this expectation may not hold true if the baby was born less than 27 weeks gestation. Nurses can help the preterm baby to achieve these milestones by providing positioning that encourages flexion of the upper extremities with adduction of the shoulders, along with flexion of the lower extremities, which will all encourage midline movements. Commercial positioning devices can be used, or a blanket nest can be formed. Nesting has been shown to decrease startle movements, improve flexion, and promote neuromuscular organization. Let's move on to therapeutic positioning. Whether assisted by commercial or non-commercial positioning aids, the goals of positioning should include alignment. The baby should always be placed in a semi-flexed position with extremities to midline and a neutral foot and neck trunk position. Assist the baby to regulate behavioral states to promote growth and interaction. Observing the baby's cues should alert the nurse or the provider to modify positioning and handling in response to stress behaviors. Provide containment, but not such a boundary that the baby is almost immobilized. Boundaries should be used to support posture and movement. Change the neonate's position in order to facilitate exposure to stimuli as appropriate to the age and physical condition. Tactile, visual, auditory, and proprioceptive stimuli also need to be taken into consideration. And always when you're changing position, you observe for stress signals because of overstimulation. Families can also be taught how to interact and position their neonate according to maturity and the overall clinical condition of their baby. They also need to be taught stress cues and what to do in response to their distressed neonate. Let's spend a few minutes discussing developmental or neuroprotective care, because positioning always needs to take into consideration the baby's ability to interact with the environment, the overall physical condition, and the degree to which the baby can tune out stimuli that's becoming overwhelming. There are 5 constructs of developmental care that can be used to help the caregiver move through the experience of the neonate. The constructs will help to evaluate the baby within the context of his or her environment, as well as the situation, to enable the provider to determine which intervention is appropriate to use now. The evaluation can also help the provider to recognize patterns of responses in order to help formulate a plan for providing care in the framework of developmental or neuroprotective care delivery. Because one provider is never always at the bedside, there needs to be consistency and continuity among providers, which means that the gathered information has to be communicated to the healthcare team as well as the family. Ideally, any information related to the developmental plan of care should be linked to the overall medical and nursing goals, including necessary interventions the baby must undergo. These 5 constructs are a simple way to incorporate all of the essentials of operationalizing developmental principles into practical application. The nurse can observe for the neonate's cues and evaluate whether the behaviors are indicating stability or stress. The nurse can also evaluate the environment and the situation to find clues to the observed behavior. How much noise is in the environment? What's happening to stress the baby out? Who is providing the stressful behaviors, and what should the nurse be doing about that? You look at the baby in the slide and you see someone is feeding this baby, but look how stressed the baby is. The fingers are splayed. There's gaze aversion. Baby needs to have that bottle taken from his mouth, help to become reorganized, re-engage with the person who's doing the feeding, and then the person can begin feeding the baby again. The nurse should consider what the best response to the behavior should be given the assessment and knowledge of the baby and the cues and the clues that were identified. If there is a pattern of behavior that seems to be recurring, he or she should identify what events are triggering these stress cues. For example, are there loud visitors at the next bed space? And that's why the baby's showing you extended arms, stiffly outstretched fingers, maybe oxygen saturations are falling. All of the information needs to be documented on the developmental or neuroprotective plan of care that was individualized for the baby. The information also needs to be reported to the healthcare team so that there is consistency in the way the providers are responding to the baby. Let's discuss different types of positioning. Holding is considered a positioning technique. We all know that babies love to be held and cuddled. It's also an essential step in parental attachment, and it's something that is difficult to do with sick neonatal patients. Neonatal units vary with their policies regarding holding. Some promote the parents to hold as soon as possible. Some have specific protocols regarding weight and extubation before parents can hold, and others have restrictions based on the physical condition of the baby. A recent prospective cohort study of parental presence and holding in the NICU found significant neurobehavioral benefits for infants that were 30 weeks and less. Reynolds found that early holding resulted in lower arousal and excitability, better quality of movement, and less stress and hypertonic muscle tone. The results of the study definitely show a developmental advantage to holding. In order to hold a baby or change his or her positioning, handling must be involved. Handling for routine care for any high-risk baby may result in increased intracranial pressure, apnea and bradycardia, hypoxia, agitation, and increased pain scores. Using body containment maneuvers will decrease both the physiologic and the behavioral responses during handling. For example, preterm infants who are swaddled demonstrate less motor disorganization and physiologic distress, better self-regulation, and a decreased need for the provider to facilitate behavioral states. It also has to be remembered that excessive handling can result in alterations of blood pressure, cerebral blood flow, and other stress behaviors. Cameron et al. In 2007 found that there was an average of 53 handling episodes, each lasting an average length of 3 minutes over a 24-hour period in ventilated, very low birth weight infants. Additionally, these infants displayed pain scores that were significantly higher after the handling episode, no matter what the reason for the handling was. It could have been for an invasive or non-invasive procedure and a social or non-social event. Those babies with periventricular leukomalacia are extremely vulnerable and reacting to handling and multisensory stimuli by increasing their already high resting heart rates even higher. Although we don't consider that a total body position change is a painful procedure, think about the sick baby who's intubated, has umbilical catheters, IVs. The handling strategies used to change the baby's position has been shown to elicit behaviors that indicate pain. In addition, routine handling and non-painful tactile stimulation elicits equal or higher levels of physiologic stress that are higher than that elicited by a heel stick. We are well aware that the neonate who is subjected repeatedly to invasive, painful procedures is highly likely to develop touch aversion, as pain is linked to the sensation of being touched. Symptoms of touch aversion include uncontrollable crying, flailing of arms and legs, recoiling when touched because of anticipation that pain is going to follow, and trying to squirm away. Babies who have been orally intubated for a period of time may develop touch aversion around their mouth and will not welcome facial stroking, rooting. They may refuse to nipple feed, and they may demonstrate a hypersensitive gag reflex. A very interesting study found that low levels of parental presence and holding in babies that are less than or equal to 30 weeks who were cared for in single rooms versus the open ward had lower language acquisition, more externalizing behaviors, and a trend toward lower motor scores. There's a relative sensory deprivation of babies who are cared for in private rooms, whose parents don't visit or hold or interact. They undergo long periods of sensory deprivation. There's no holding, no auditory stimulation, the lack of a human presence. And that is likely to be as detrimental as a sensory overload of being in a noisy, open NICU. Holding and positioning are required for healthy neuromuscular neurodevelopmental growth. And it's recommended that if this baby's in a private room and there's no family, there's nobody interacting with them except the nurse that is providing the every 3 or 4 hour care, that baby be removed from that room and placed in the open NICU. Parents should be encouraged to be present in the nursery and be actively involved in the care of their babies, including skin-to-skin holding. Well-known factors that discourage parents from visiting include the excessive noise levels in the NICUs, high light levels, and dismissive staff attitudes. As the modern units of today take into consideration light and noise levels, as well as the space needed to provide family-centered care, many of these factors are decreasing. When you see the NICU in the slide, it doesn't look very welcoming. Very bright, probably a lot of noise, and nobody's turned around to say hi when we walked into the room. Everybody is very task-oriented, and it doesn't look like there's any place for parents. Kangaroo Care, or skin-to-skin care, has been used in North America for the last few decades and has met with wide acceptance in some nurseries and with reluctance in others. Kangaroo Care consists of having the baby placed vertically on the mother or father's chest, and it has been shown to have benefits for both the parents and the baby. It's well tolerated in the first week of life by preterm infants with current or resolving illness. Babies that experience Kangaroo Care have significantly decreased heart and respiratory rates and increased temperatures and increased oxygen saturations. A randomized controlled trial of 3 holding methods of Kangaroo Care, cuddling, and a no restrictions holding method in preterm babies aged 32 to 35 weeks concluded that both Kangaroo Care and cuddled holding by parents provide equal developmental benefits in the form of early behavioral organization. Parental holding is often not encouraged or is limited in some NICUs, and this is an easy neuroprotective positioning strategy. Transferring a baby from an incubator to the parent for Kangaroo Care or for holding can be stressful to the baby. Norris et al. Evaluated physiologic disorganization in preterm babies whose nurse picked up the baby and handed the baby to the parent as compared to the parent standing by the incubator and picking up the baby herself or himself. Both of the methods of transfer resulted in increased physiologic and motor disorganization, decreased self-regulation, and the need for the provider to help maintain physiologic stability for about 6 to 9 minutes. Disorganization was shown by decreasing oxygen saturations, increased heart rate, hypotonia, and color changes. But the results show that the baby's vital signs returned to baseline faster when it was the parent who was the one who accomplished the transfer. They picked up the baby, nurse is helping, they pivot and sit down. Barriers to using Kangaroo Care include safety concerns such as unplanned extubation, loss of umbilical or peripheral lines, and the neonate's physiologic instability. There may also be reluctance on the part of the healthcare professional and the parents to initiate and or participate in Kangaroo Care. The nurse might voice concerns about an increased workload, difficulties in providing care when the baby is being held, a lack of experience with Kangaroo Care, may say that the baby isn't developmentally ready, or that the technology, whether the baby's in an incubator or warmer, is actually better than the parent. Everything that is done in a NICU has risk and benefits, and it's up to the provider to determine the baby's individual risk and benefit. There can be infants who are too unstable because of ventilator requirements, chest tubes, pressors, etc. And it's up to the care provider or the nurse to make that determination. There is selection criteria developed for Kangaroo Care for infants requiring mechanical ventilation, and this has provided foundation for many hospital policies. The criteria was developed by Susan Ludington Ho, who, as a nurse researcher, has got a program of research in Kangaroo Care and is considered to be an expert. Her criteria include the baby having a birth weight of equal or greater than 600 grams and be greater than or equal to 30 weeks, have been on a ventilator for at least 24 hours before the first Kangaroo Care to make sure the baby is stable, low ventilator settings such as a ventilator rate of less than 35 with oxygen of less than 50%. The baby overall has stable vital signs and oxygen saturations, stable blood gases and bilirubin levels, that there's no signs of sepsis or symptoms of sepsis to make the baby seem unstable, and not receiving vasopressors and does not have a chest tube. Her criteria also has lines being well secured, Broviac, umbilical, arterial, even peripheral IV lines. I know of many institutions that if you have central lines like a Broviac or umbilical lines or any arterial line, that's a contraindication in their hospital policies for holding a baby. Kangaroo Care is a simple, cost-effective, and safe intervention that reduces severe infant morbidity without serious side effects. However, more well-designed, randomized control trials are needed. When you look at the literature, we really only have data on babies that are 32 weeks and greater, and we have very, very little studies on those babies that are 27 weeks and less. Parents require consistent information and communication from the bedside nurse and provider to become comfortable and knowledgeable, and should have individualized support when engaging in Kangaroo Care. Perhaps there can be written materials that discuss the benefits of Kangaroo Care, how the parent should be prepared to engage in Kangaroo Care. For example, what to wear, the suggestion to make sure that you go to the bathroom or get something to eat beforehand because we want the parent to spend some time at that bedside, much more than just 10 or 15 minutes. Healthcare providers also need education regarding Kangaroo Care and its benefits. They need to develop the competencies in order to skillfully transfer the baby and the parent with confidence and evaluate the baby and the family during Kangaroo Care. The institution should develop protocols that contain the criteria for when to initiate, how to position, how to transfer to and from the parent, and what care practices can be done while the family is engaged in Kangaroo Care, and what interventions to undertake when the neonate or the family exhibits instability. Positioning. Ideally, all neonates should have continuous assessment of their muscle tone, oral motor function, and response to position, handling, and stimuli to provide a baseline of data so that interventions can be truly individualized. This may be once an hour for the critically ill baby to once a shift for a stable, growing, feeding baby. Realistically, some of these things are part of a routine assessment, but not all are evaluated by either nurses or physicians. The overall goal of positioning is to provide opportunities for positive development and organization of all the sensory systems, detect developmental problems early, and education of the parents regarding how to appropriately stimulate, handle, and position their high-risk neonate. Positioning seems so easy, so why is it so important? Because properly positioning the neonate decreases stress and enhances comfort. For example, stressed babies will grab at their endotracheal tube because grasping something is reassuring. It's a hand-to-mouth behavior that's self-consoling. Positioning is also very important in helping to develop anti-gravity movements. We discussed earlier that the preterm baby has a very difficult time with gravity because of those type 1 muscle fibers. Positioning is also important in inhibiting and/or shortening the dystonic phase while the neonate remains flexed or in a fetal position, which is very important in decreasing agitation. Positioning is also essential in facilitating hand to midline and midline orientation. The more preterm the neonate, the less well-developed the physiologic flexion is in the limbs, trunk, and pelvis. Sick neonates can have long periods of little movement or immobilization without a positioning device lying on the mattress of the warmer or incubator, and that mattress is very firm. Without good positioning, gravity can cause abnormal development, like increased neck extension with a right-sided head preference, shoulder retraction, and adduction. That will reduce forward rotation and the baby's ability to reach midline. Increase trunk extension with arching of the neck and the back. A frog-like position where the hips are abducted and externally rotated, and ankle and feet eversion. Any of these deformities can interfere with the development of eye-hand coordination, head control in prone, sitting, crawling, walking, cognitive development, and equilibrium. You can see the baby in the picture is very poorly positioned. The head is turned too far to the left, and there is a lot of traction on the endotracheal tube. And you also can see that there is no support for the baby's trunk and extremities. The baby should be placed in a variety of positions to enhance development of flexor tone and prevent overstretching of the joints, deformities, and unplanned extubations. Goals of positioning should include optimizing alignment, semi-flexed, midline, extremity posture. That means a neutral neck, trunk, and foot positions. Supporting posture and movement within containment boundaries. That's avoiding producing a barrier of immobilization. Modifying positioning and handling to support behavioral state regulation of sleep and wake states. Providing positions that encourage controlled, individual exposure to stimuli while monitoring for signs of behavioral stress from overstimulation. And then the nurse would adjust the stimuli accordingly. The side-lying position is invaluable in helping to improve the baby's visual awareness of his or her hands and encourage the hands to mouth midline movement. Use of this position prevents that frog leg position, which can interfere with hip development and lead to problems with walking later on. Bringing hands to the mouth for sucking and self-comforting decreases the baby's agitation. Single blanket rolls can be used to help maintain the baby in a position. Use of swaddling or commercial positioning devices keep the baby in the proper position better. When using the side-lying position, the baby's extremities should be positioned so that the bottom arm rests comfortably and the upper shoulder and hip are positioned slightly in front or forward of the lower shoulder and hip that is weight-bearing. A small positioning device can be placed for security, but not so close that the upper extremity then hinders chest expansion. The side-lying position also allows both sides of the head to be alternated, which decreases head molding. In the case of a preterm infant with respiratory distress, changing sides is also important to prevent atelectasis of the dependent lung. When using the position, the head and trunk must be maintained in a neutral alignment such that the trunk and the head remain in the same vertical plane. The left lateral position has been associated with improved oxygenation, improved lung mechanics, and breathing patterns in preterm infants. These positive outcomes are similar to those found with the use of the prone position. The baby in the slide is positioned too far forward with the right arm not forward enough. Should have positioning devices in the front also to help stabilize the baby. I think the baby looks pretty uncomfortable. You can see that the endotracheal tube also has excessive dead space, and that can be putting pressure on the palate and hypopharynx because of that position. And the danger of that is there's the possibility of creating grooves in the palate which will interfere with later language development. The supine position is frequently used when the neonate requires mechanical ventilation, umbilical catheters, chest tubes, and other equipment used in the care of the high-risk neonate. The baby should never be placed supine with the head turned to the left or the right side because this encourages mechanical obstruction of cerebral venous return. It promotes irregularities in cerebral blood flow, both of which may contribute to an intraventricular hemorrhage in the preterm baby. It is important to keep in mind that the supine position doesn't encourage flexion, and because of lack of boundaries, it can be very stressful to sick infants. When in the supine position, neonates display increased startle behaviors, motor disorganization, increased energy expenditure and agitation, and sleep disturbances. If you're going to use a water or gel pillow when the baby's in a supine position, it should be placed under the head and neck down to the nipple level to prevent neck flexion to help provide comfort and maintain neutral alignment. The supine position should promote as much flexion as possible. Containment also needs to be provided to promote the baby's feelings of security, enhance quieting and self-control, increase physiologic stability and energy conservation, decrease physiologic and behavioral stress, and help the baby to better tolerate that stress. Without the use of positional supports to maintain the position, many neonates travel. No matter how many times they are repositioned, they keep moving to the sides or the bottom of the incubator, which can place traction on the endotracheal tube and may result in an unplanned extubation. The use of commercial or non-commercial positioning devices can be placed to provide a boundary that will halt that migration. The boundaries can also aid in conserving calories for growth and development, as many acutely ill neonates are agitated when in the prone position, as discussed earlier. Thrashing of extremities, color changes, increased heart and respiratory rates can also be decreased by the use of a nest to provide boundaries and the security like the uterus provided. The prone position really supports the neonate and facilitates the development of neck extension and flexion of the extremities. Positioning devices can include a sling or a small hip roll to help the neonate maintain flexion. There should be a secure lower boundary for foot bracing also. Head support can be provided with the use of a gel or easy flow pillow. The pillow can be placed under the neonate from the top of the head to the umbilicus to provide elevation of the body for extremity flexion without placing excessive pressure on the knees and elbows. The positioning device will then allow the shoulder to round forward over the top of the roll and encourage the legs to flex over the bottom edge of the roll. While manipulating the baby in the course of positioning, the use of body containment maneuvers can help maintain the baby's self-regulation. The baby can hold on to a finger or hand, or the provider can cross the neonate's arm in midline and securely hold him there. Safe swaddling will position the baby's extremities in slight flexion and abduction. Being wrapped in a blanket or a commercial positioning device with extremities flexed stimulates in utero positioning and provides comfort and security. Swaddling also improves flex position and flexor muscle tone, facilitates behavioral responses, and improves development of the primitive reflexes. Moving the neonate, whether for repositioning or holding, is always a risk for unplanned extubation. Picking up a baby from a supine position often produces startles, apnea if the baby's preterm, and head hyperextension. A better technique is to roll the infant prone, which flexes the head, then flex the limbs onto the trunk and pick up the infant. You can also swaddle before picking up the infant. As discussed previously, when picking the baby up for Kangaroo Care, have the mother or father stand at the bedside and help place the neonate on his or her chest. While the nurse stabilizes the endotracheal tube and any equipment and IV lines, for example, the mother or father can then pivot and sit down in the chair. This is a much more stable transfer technique with a lessened risk of unplanned extubation. And we also have better physiologic stability with the baby. We have discussed motor and musculoskeletal development, the use of therapeutic positioning, and positioning to prevent unplanned extubation. Given our knowledge of growth and development and neuroprotective strategies to enhance positive outcomes, it is impossible to even think of positioning a neonate and not use a developmental approach. Thank you for attending our educational program.